All right, today we'll dive into a case report that looks at a young nationally ranked swimmer with lateral knee pain. It's a case report, so it's kind of brief in terms of the amount of information from the study itself, but I want to discuss as well topics surrounding the meniscus in particular, and of course using patho-anatomical diagnoses all the time versus looking at pathophysiology. That is, moving patients and trying to understand if this really is a problem of function or physiology, or is something structurally compromised? Is anatomy actually broken? And that's the problem. And as you may know if you follow me, I repeat and repeat and repeat that most problems of health have to do with physiology, have to do with how things are functioning. They're not structurally compromised. And if there is a structural problem, which arises especially as we get older, we get dings and little scrapes and things that have happened to us over time, they may be problems with anatomy, but they're probably not the problem, right? They're probably not the thing causing symptoms. And a discerning clinician has to figure that out, whether or not the cut on your skin is just a scar that's been there forever, or if it's actually relevant to your problem, for example. So the study titled Directional Preference at the Knee, a case report using mechanical diagnosis and therapy. Directional preference is a term that I use. People who use MDT learn that term, and it means the movement that when applied, or the direction of movement when applied repeatedly to a joint, basically fixes the pathophysiology, fixes the joint derangement problem. Mechanical diagnosis and therapy, kind of a mouthful, also known as MDT or the McKenzie method, and the core tenet of MDT is repeated movement testing. Done by Greg Lynch and Stephen May in 2013. Greg Lynch is a faculty member with the McKenzie Institute, and he was the diplomat of MDT who performed this patient case report. The patient is an 18-year-old female swimmer, nationally ranked, had an opportunity to compete at some college in the US on a scholarship. She initially went to her GP. Her general practitioner referred her to physical therapy with a lateral meniscus tear, claiming a positive McMurray's test. And the patient was told to take ibuprofen and attend PT if not, if the ibuprofen didn't resolve the problem. The patient took the ibuprofen for a week or two and it had no effect, and she subsequently sought out some physical therapy. Now, I'll pause here to say the McMurray's test is a commonly used test to assess for a meniscal injury. There's also the duck waddling test, the Thessaly's test, the Apley's test. There's joint line kind of palpation, compression testing. And these tests are not perfect. They do not have 100% sensitivity and specificity nor reliability. And so what I've learned by using MDT is to really question the validity, the veracity of all of these tests that purport to look at pathoanatomy, right? These tests are at their best claiming that there's a problem with the anatomy, with the meniscus. And even if they do that successfully, right, the patient or the clinician, has to decide if that anatomy is the patient's problem. So even if these tests were perfect, you still need a clinician who knows how to interpret those tests in the presence of the verbal history, in the presence of the baselines, in the presence of every other piece of that patient's presentation or that puzzle, so to speak. So I can use these orthopedic special tests when needed, but I take them with a grain of salt because in some patients, and more readily with patients who've had obvious trauma to their anatomy, they are positive and they are valid and they dictate treatment, which is often either wait for the anatomy to heal or surgical considerations. But for the vast majority of patients who don't have anatomy problems, if we do these tests, and I don't do them very often, if we do these tests, we have to, again, put them into the complex puzzle of the patient and ask ourselves, is this test positive and it's true, or is it false positive? And if it's true, is it possible that something else is causing the patient's pain? So maybe the meniscus is torn, but something else is causing the meniscal or the knee pain. So going back to the patient's kind of progression, I will add this as well. New research is highlighting how so many different synthetic things can affect the gut microbiome, the epithelial intestinal lining, and therefore systemic health. So whereas before, when I was younger, I really did believe some Advil or some ibuprofen was benign, I've come to the conclusion that it's not. And I tell patients that we can use these things. I can't prescribe medicine, but they can be used over the counter if necessary. But my druthers is to reduce the amount of things, especially pharmaceuticals, that we're putting into our bodies if we don't have to. So there's new studies coming out, and I want people to be more considerate of what they're putting into their bodies and not just thinking that, oh, it's just over the counter, it's fine, or it was prescribed and therefore it's fine. These things are foreign to the body and not necessarily useful. And this patient had no effect by taking ibuprofen. So unless it's absolutely necessary for me personally, I'm not taking certain things like this. And I might look for more natural remedies if I actually think that inflammation is the problem. So again, these things are not going to heal meniscus, right? They can deal with pain and inflammation if that's the case, but they're not healing in and of themselves of the root cause. So the patient had no effect from the ibuprofen, sought PT, went to physical therapy, had 8 visits, no effect, hamstring stretching, quad strengthening, some maybe ultrasound or electric stim, something else, or heat, kind of traditional physical therapy, the things I may have done 5 to 10 years ago. And then she went back to her GP, and the GP said, okay, I think you need a surgical consult. But intervening was her swimming coach, who said, before you see the surgeon, I'd like you to see Greg Lynch. I'd like you to go to his physical therapy clinic. I mean, I'm assuming the coach said something along the lines of he does things differently, because repeated movement testing is different than what 99 out of 100 clinicians who use orthopedics do, right? Which is unfortunate in my mind, because I think repeated movement testing is the #1 test for orthopedic complaints. It's just harder to learn than doing a quick McMurray's, right? Or a quick joint line tenderness test and saying, oh, it's the meniscus. So the patient presented to Greg Lynch, and let's go over her history. So the pain was in her lateral knee for 5 weeks. She started noticing it during a heavy kicking session with her swim team, but there was no instigating sudden event that caused the pain. The pain was intermittent. It was worse when walking downhill or downstairs, worse with squatting, worse with lunging with the right knee forward, worse with kicking with swimming. Prolonged standing at her part-time job would also make her worse. And as the day progressed, it tended to be worse overall versus in the mornings. The patient did not report any clicking of the knee or swelling. And clicking is one of the features that clinicians are looking for when they do tests like the McMurray's. And her McMurray's test did not have that clicking present. Her average pain was 6 out of 10 at worst. It would rise to an 8 out of 10. And her functional scales that they used for this patient were lacking. So she was not fully functional. She was not able to compete or practice or perform life like she wanted to. Her baselines, so she came to see Greg Lynch, her baselines in the first visit, 10 degrees of loss of knee extension with end range pain, 20-degree loss of knee flexion with pain as well. Positive McMurray for pain and apprehension. So again, not for clicking or thunking or thudding or clunking of the knee, but for pain and apprehension on the patient's part. So they also looked at resisted flexion and extension of the knee, which is just a typical kind of MMT, manual muscle test of the knee. It was painful, and she reproduced her pain with a squat, which is something I would call functional baseline. So baselines for my orthopedic exam: range of motion, strength, sometimes nerve tension, and a functional test, like my knee hurts when I squat, or my shoulder hurts when I lie on it, or my hip hurts when I rise from the chair. Something that I'm always asking patients, what can we do right now that would recreate the reason you're here, recreate your familiar symptom? Because that's really important to get if you can in the office. If not, you just have to do it between sessions, which is gauge the effect of the intervention on that function. So they use the squat later as a reassessment tool. So visits. On visit 1, the clinician looked at repeated flexion of the knee 10 times, so 10 flexions of the knee passively, and then got up from the table, had the patient do the squat again. I'm assuming, because I do the same thing, he chose the squat because it was a very clear baseline, right? It's either better, worse, or the same. Do the repeated movement, do a baseline again. And as clinicians, I'm choosing which baseline to do again because I usually don't have time to go through all of the baselines. I'm doing the one that I think, for various reasons, is the most important for that patient. And oftentimes it's the one that relates most to the patient's pain, or it could be the one with the biggest range of motion loss, for example. So worst squat. So the clinician moved on. He looked at repeated active extension and sitting. So that's just the patient sitting on the edge of the table, extending her knee, just like a long arc quad. A few of those, no effect. He looked at the range of motion this time. No effect on the range of motion after some seated active extension. So then he did repeated extension, supine. The clinician did it kind of like passively, probably pressing on both sides or above and below the knee into some end range extension. And after doing some of those, her range of motion improved. So the patient's homework, because of the positive response to extension of the knee and a worsening response with flexion of the knee, and the clinician taking into consideration the patient's total picture, right? What she was lacking in terms of range of motion, what was painful. We know that for younger people, the prevalence of knee extension is more common than knee flexion in terms of resolving a diagnosis of joint derangement. In any event, she went home with repeated knee extension and sitting, and her there's a picture in the article online, which is wonderful. Her heel is supported on the ground, so there's some weight bearing going through the lower limb, and she's pressing above her knee into knee extension in sitting. And I did a video on that recently as well, that you can kind of see how that individual maneuver is performed. So she was asked to do it 10 reps every few hours. And then she came back 4 days later, reporting 30% overall improvement. They decided to keep her with the same exercise. And then she came back at 7 days, so 3 days after that, saying that her pain was about the same, but she was improving in terms of the amount of function she was re-adding to her life. They looked at doing the knee extension and standing this time, which is more weight through the lower extremity. So standing against the wall and pushing that knee into extension in standing. So it's basically knee extension actively with some overpressure at end range to get to full end range knee extension. She went home with that home program. She came back on day 13 saying, again, function is getting back. She's doing more swimming, etc. She got 75% better overall. They did not change anything. She had that for another week. And so finally on the 20th day of the treatment plan, she reported more than 95% better, back to doing most things in her life. Obviously, if she's 95% better. And the McMurray's test now was negative, right? I think it might have been negative on visit 4, but this illustrates the fact that you can have a positive anatomy test. Yes, this test says your meniscus is the problem, but once you fix the joint with directional preference movement, in this case, knee extension for this patient, repeatedly throughout the day. So over the course of 20 days, she's probably getting 2,000. She's probably getting about 100 a day, maybe less. But that's what repeated movement testing means. It means repeated. It's not 10 or 20. But it takes only a minute to do 10, maybe a minute and a half. It's very quick to do. The frequency is just the harder thing to get throughout the day. So her test became negative. So that calls into question the difference between, again, pathoanatomy and pathophysiology. Now, when I was in school, I took anatomy and physiology class, and I just think I wasn't really equipped to treat physiology. I mean, in a way we were, because we were given all these ideas of pathophysiology like ITBS syndrome and patellofemoral pain syndrome, and these convoluted ideas about how these multiple parts of physiology just fail, right? Something gets tight and something gets weak, and something anatomically is misshapen as well, which is why this problem is more likely in this particular patient. So we were given some ideas of physiology, but when I think about mechanical diagnosis and therapy, mechanical meaning how things move and how joints move in particular, I feel like this really gives me an algorithm to figure out, is this anatomy in the small amount of people, especially people who've had recent acute trauma, or is it something not moving right? Is it physiological, functional? And if it is, can we find that specific kind of magic direction that gets that joint back on track and moving appropriately and feeling normal again? So her overall care, 5 visits over 3 weeks, and she had 2 exercises. In effect, she had 1 knee extension, but for the very beginning of care, she did it seated, and then they progressed to more weight bearing and standing. So you can call it 2 different exercises, but this is such a contrast to traditional conservative care, right? Which is why I get upset when I read that people went to surgery or remained with the pain despite traditional conservative care or exhausting conservative care, because I know that in 99% of the cases, they did not get mechanical diagnosis and therapy. They did not get repeated movement testing. So one of my goals, again, is to get the word out that repeated movement testing is essential for orthopedics and helps clinicians determine what anatomical tests are actually true and what aren't. And if you learn repeated movement testing, you'll find that, over half of patients with knee pain have a mechanical problem in their low back, in their hip, or in their knee that has a directional preference. One movement that, when done repeatedly, restores the joint to normal and gets the person back to pain-free function. So yes, this is not what people are getting when they're saying, oh, I went to PT and I didn't get better. Okay, let's try a different type of PT, right? Let's try repeated movement testing. Let's try physical therapy or chiropractic or any other clinician who uses repeated movement testing. Let's try their care based on a repeated movement test. So I put these up here. I can write the names of these studies as well, but I wanted to remind myself to discuss briefly how there's not a lot of good evidence for meniscal surgery. In 2017, they looked at about 150 patients. They randomized them to placebo surgery or surgery for degenerative meniscal tear, and there was no significant difference in their outcomes at 2 years. And then they re-looked at those people in a study of 2020 at the 5-year follow-up, and again found no big difference between placebo and actual surgery for the degenerative meniscal tear. Now, in 2005 and 2002, there were also some studies that look at the prevalence of meniscal tears in asymptomatic individuals, and they find some discrepancy between the type of meniscal tear that's usually in symptomatic versus asymptomatic knee. So those are some interesting studies to look at. But they're starting to, even though those studies were, 20 years ago in some cases, at least people have started to question whether or not these anatomical flaws are actually patients' problems. So again, I'll link to these studies. Hopefully I've gone over everything I wanted to go over. If you have some questions, please feel free to leave them in the comments. I'll do my best to answer. But if you're struggling with knee pain or any other pain, especially if you've been attentive to care, if you've been doing what other clinicians have asked you to do and you've not been getting the results that you want, consider finding a clinician who is trained in MDT or the McKenzie method and really knows how to apply repeated movement testing for you to figure out if indeed you have a joint derangement that can be fixed with movement repeatedly into one direction.